Hello, and welcome to my proposed study on the impact of community-based postpartum care on maternal and newborn health in rural, low-income areas. This presentation will go over a brief introduction followed by some background information, the objectives of the study, methods used, statistical issues, ethical issues, limitations of the research, and a brief summary, and followed by references used. The purpose of this study is to identify the impacts of community-based postpartum care in rural, low-income areas. It will examine how home visits with trained community health workers, coordinated breastfeeding education programs, and accessible mental health resources influence maternal health outcomes such as physical recovery, mental well-being, and breastfeeding success rates. In addition, it will assess how these supports impact newborn success rates, such as growth metrics, parental bonding, and infant survival. Maternal and infant health outcomes are key measures of society's well-being as a whole, yet there remain significant disparities in low-income rural areas. Due to the limited access to healthcare resources, geographic restrictions, and socioeconomic barriers, women living in these communities have a higher risk of postpartum complications, maternal mortality and morbidity, and a higher negative neonatal outcome. Globally, the World Health Organization estimated that around 287,000 women died during or following childbirth, with 95% of these maternal deaths occurring in low-income or low-resource settings. In the United States, the highest rate of pregnancy-related deaths happen in the postpartum period. According to the CDC, women in rural areas are 60% more likely to die from pregnancy-related complications compared to those living in urban settings, likely due to less prenatal and postnatal healthcare services. Infants in rural communities are at a higher risk of infant mortality and low birth rate compared to urban communities, which is likely linked to maternal malnutrition, inadequate prenatal care, and a lack of access to specialized care. Postpartum depression is also a concern, with 20% of new mothers being affected by PPD, due to hormonal changes, psychosocial factors, and stress. PPD can hinder mother and baby bonding as well as affect infant development. Lactation challenges due to the lack of breastfeeding support can lead to early cessation of breastfeeding, which can put an infant at a higher risk of infection and malnutrition. Women in these low-income rural areas struggle with transportation difficulties, financial barriers, and provider shortages, resulting in reduced timely access to postpartum care. I will now go over previous research related to this topic. The first study focuses on exploring postpartum care in rural Arizona. It identifies key barriers to care such as transportation, health literacy, and financial constraints. Its strengths are robust qualitative methodology, ethical standards, and presents clear findings and policy recommendations. Its limitations are its limited generalizability, potential sample and researcher bias, and a lack of depth on systemic issues. And there's also no quantitative validation. In conclusion, this study offers valuable qualitative insights and the need for better community-based postpartum care. The second study focuses on the postnatal experience of women living in Canada. It captures lived experience, making findings relevant for identifying gaps. The strengths are a comprehensive methodology, a large sample size, and identifies key gaps. The limitations are its limited generalizability, it's a one-time snapshot of what is happening, and it does not address low-income rural care. In conclusion, it provides useful understanding of general gaps and provides valuable background information, but needs to be supplemented with longitudinal studies to measure long-term impacts. The third study focuses on how home visits and cognitive behavioral strategies can help improve maternal mental health and suggests that reduced maternal stress can lead to better infant outcomes and longer breastfeeding rates. Its strengths are it demonstrates the benefits of home visits and highlights the indirect link to newborn health. Its limitations are it lacks direct focus on breastfeeding and does not account for socioeconomic differences. In conclusion, it provides strong evidence for the importance of maternal mental health and supports home visits as an effective intervention. The last study focuses on the relationship between food insecurity and breastfeeding trends among low-income mothers and what other factors can impact these outcomes. Its strengths are it's relevant to the research question, has a diverse low-income sample, and identifies correlations between food insecurity and breastfeeding patterns. Its limitations are it doesn't explore the impact of breastfeeding support interventions, and mothers may underreport breastfeeding challenges and doesn't provide causal conclusions. In conclusion, this study highlights the connection between low-income populations and lower breastfeeding rates and emphasizes the need for home visits. The gaps in knowledge: limited research in low-income rural areas, a lack of integrated approaches, and overlooked cultural and social factors. The importance of this research: community-based interventions could bridge healthcare gaps. It could provide improved health outcomes by lowering maternal and infant mortality rates in underserved communities. It could provide health equality and address disparities in vulnerable rural populations. It could be cost effective by reducing hospital readmissions and increased breastfeeding rates justify funding. It can also lead to policy improvements by informing policymakers on the need for expanding postpartum care in low-income rural areas. The objectives of this study is to identify research gaps in postpartum care, present effective practices to help guide policy and program development, evaluate effectiveness of community-based postpartum care in underserved populations, and improve maternal and newborn health outcomes. The study design will use a prospective cohort study with mixed methods. This allows for measurable effects of community-based postpartum care to be captured, along with the personal experiences of those involved in the study. The intervention group will be the one with the access to the community-based postpartum care, and the control group will receive the standard care. The inclusion criteria include mothers aged 18 to 45, low-income households, can be first-time or experienced mothers, must be in the postpartum period, can provide informed consent and willingness for a 6-month follow-up, infants born at 35 weeks and above, vaginally or cesarean, and mothers must live in rural Ontario and have limited postpartum care access. The exclusion criteria are mothers with any pre-existing medical conditions, maternal complications requiring extended hospital stay, newborns with major congenital conditions, mothers unable to consent or commit to follow-up, and premature births at less than 35 weeks. Subject recruitment strategies are working with local health organizations such as public health units, clinics, and midwife offices. Social media outreach through Facebook groups for new mothers or in-hospital recruitment, and a standardized screening conducted prenatally, in-hospital, or via the phone. The exposure intervention variables is the access to community-based postpartum care. This includes home visits, in-person, at-home postpartum supports that are provided by healthcare professionals or community workers. Provide postnatal checks, baby weight checks, social supports, and infant care education. This is measured by participation within 6 weeks of delivery, frequency of the number of visits, and the length of visits. It also includes mental health supports, psychological services, one-on-one counseling, support groups, referrals to mental health providers, and this is measured by a yes or no access to any of the services. If yes, what type and the frequency. Lastly, it includes breastfeeding education, so one-on-one or group sessions / workshops on lactation techniques, troubleshooting common breastfeeding issues, and other supports. This can be done through a telehealth line for advice and measured by participation in sessions or telehealth, frequency of access, and if the mother had success post-sessions. The outcomes are maternal health, which is the mental health measured by the Edinburgh Postnatal Depression Scale, or personal feelings of mental health status, depression, anxiety at the start of services versus the 6-month follow-up. It includes physical recovery, self-reported surveys, pain, sleep, C-section recovery, and infection rate. It'll also measure the newborn health outcomes through physical growth, taken at initial visit and 6-week follow-up and a 12-week follow-up, that are then compared to the World Health Organization growth charts. Also be measured by hospital readmissions for jaundice, failure to thrive, dehydration, infections, and this will be measured by hospital or clinic notes. Secondary outcomes are maternal confidence. They are self reported confidence of the mother to care for the newborn, measured by surveys or parenting competence scales. Also, measures social supports, perceived level of social supports through family, friends, community, measured by a survey, healthcare utilization, how often the mother accessed available services, and measured by attendance records, telehealth records, or self reported use. The hypothesis of this study is access to community based postpartum care, including home visits, breastfeeding education, and mental health supports, significantly improves maternal and newborn health outcomes in rural, low income communities. The study will use quantitative analysis through descriptive analysis by calculating percentages, averages, and standard deviations. We'll also use comparing continuous outcomes through a t-test or ANOVA to compare averages of those with care and those without care. It will also compare categorical outcomes through chi-square tests, proportions between the intervention and control groups, and multivariate analysis, but through the use of a regression model to adjust the data for any confounding factors. It will also use qualitative analysis through thematic analysis, identifying any recurring themes or trends from interviews or focus groups, and it will also use data management software. The ethical considerations for this study is informed and voluntary consent of participants. They will be provided with an understandable information package explaining the study and informed of the right to withdraw at any time. It will also take into consideration the confidentiality and the privacy of the participants through a secure storage of the data, and everyone involved in the study will sign a confidentiality agreement. It will also look at the inclusion and equality through equal opportunity to participate regardless of race, ethnicity, or cultural background, and avoid any unintentional exclusion. The potential risks will also be discussed with all participants and explained any postpartum challenges that could cause emotional distress or social stigma. We will provide a safe environment and mental health supports for everyone to access at any time during the study. The benefits will also be communicated to all participants of the impact of the study. We will do this by working with community organizations to ensure any benefits from the outcome of the study are continued in the communities and others. We'll also obtain oversight and approval. We will obtain approval from the Research Ethics Board before study and maintain compliance throughout. Some potential challenges with this study are the high cost of research, expenses such as travel, recruitment, and services. Solutions for this are applying for grants, collaborating with local organizations to offset the cost. Another challenge could be self-reporting bias. Reliance on self-reported data could cause inaccuracies. The solutions for this is the use of standardized scales, anonymous surveys, and medical records. Another challenge is limited availability of resources, a shortage of staff for healthcare services, and a solution to this is partnering with local public health units and clinics to provide staff. Lastly, a potential challenge is retention challenges, difficulty maintaining participant participation and follow-up. The solutions to this is providing incentives like baby supplies and gift cards and sending follow-up reminders via text, phone, or email. In summary, past studies highlight the need for better postpartum care in underserved populations. A major gap still remains in understanding the impact of multiple interventions on creating better postpartum care in rural, low-income populations. Community-based postpartum care that provides home visits, breastfeeding education, and mental health supports has the potential to offer significant benefits to mothers and babies. This research study can provide the evidence to support funding and policy recommendations for more standardized community postpartum care for those who live in low-income and rural areas. Thank you for listening to my presentation, and these are the references used throughout the presentation. Thank you.